4 मिनट एक शुरू करता है या
इसको टाइमिंग कितनी आएगी? टाइमिंग शो है,
कितनी मिनट का लेक्चर है?
मैं वही देख रहा हूँ। कौन सा है इसमें टाइमिंग? सर इसमें टाइम मेंशन नहीं हो रहा। इस मैडम सर पीपीटी है असल में। सर इसमें वॉइस एम्बेडेड है। सर इसमें वो शो नहीं हो रहा।
आईटी के एक्सपर्ट ऐसा कैसे हो सकता है? कितनी देर में कितनी रिकॉर्डिंग है ना? रिले करोगे तो वीडियो रिले होगी ना?
नहीं सर ये पीपीटी पे है ये ऑटोमेटिकली चल रहा है।
आवाज भी आ रही है?
जी सर आवाज आ रही है।
और ये पता कितनी देर का?
जी सर।
कितनी देर पीपीटी की?
सर 34 स्लाइड्स है।
हाँ
34 स्लाइड्स।
कभी प्ले करके देखो
मैडम आप बोले प्ले कर दो।
प्ले करके आगे करके देखो
वहां से प्ले करना।
अच्छा वहां से प्ले करना पड़ेगा।
मैं वो करवा देता कोई शादन नहीं हो जाएगी हो जाएगी। ठीक है मैडम।
पता चला वो लेक्चर आगे आ जाएगा अच्छे लोग आ जाएंगे।
नहीं कर रहे हैं उसको प्ले नहीं करवाए बंद। बस एक मिनट रह गया। नहीं पता उसको बोल दो कर दो। उसको बोले कि आवाज आ रही है नहीं हमारी आवाज आ रही है ना वहाँ पे से पूछ ले सर क्या नहीं वहाँ पे आवाज आ रही नहीं आ रही आएगी मैं देख लेता हूँ। ठीक है ठीक है सर।
Good afternoon, ladies and gentlemen. So welcome you once again to the last, but obviously not the least session of the evening. So I'm pleased to chair this session along with my co-host, Professor Dr. Prevalence. So in this session, we have two renowned scientists to talk about. The first speaker is Dr. Kareem Al-Asri from Johns Hopkins University. He is actually a consultant gynecologist, oncologist, and currently working as an associate professor in the field of obstetrics and gynecology. He is affiliated with the Medicine Hospital and Muhammad bin Rashid University of Medicine. He is going to deliver his talk online, which is actually recorded. But if you have any questions, so you may note down and let us know, or you can also note down his email address and contact with him later on. So with this, I would request to kindly start this lecture, please.
Good afternoon, my dear friends and colleagues. I'd like to begin by thanking the organizing committee for inviting me to such an important and prestigious meeting. I'm sorry that I'm unable to be with you in person today, but hope to be there in the future. I'm delighted that this meeting is being held in Pakistan, as I feel that there's much work to be done. For the sake of this meeting, I have no financial disclosures to make. By the end of this presentation, I hope to be able to convince you that apart of cervical cancer, HPV has an important role in other cancers, and therefore its elimination will significantly reduce the burden of disease. In the first part of this presentation, I'll be briefly discussing cervical cancer and the role of HPV. In the second part, I'll discuss the role of HPV in other cancers and genital warts. And finally, I'll conclude with the WHO call for action. In order to improve the health of the nation, the burden of cancer needs to be tackled. Cancer is the second commonest cause of death, with over 19 million new cases reported in 2020 and over 10 million cancer-related deaths. In women, the number of new cancer cases was over 10 million, with nearly 4.5 million deaths in 2020. Globally, cervical cancer is the fourth commonest cancer in women and the fourth commonest cause of death. In 2020, there were over 600,000 new cases of cervical cancer reported, with nearly 350,000 deaths due to it. This equates to one new case being diagnosed every 50 seconds and one death every 2 minutes. So since the beginning of my talk, there have been 2 new cases reported and 1 death. So you can see that the elimination of cervical cancer would significantly reduce the burden of cancer. But what exactly do we mean by talking about the elimination of cervical cancer? And is it really possible? Well, to answer the first question, what is meant by elimination is the reduction below 4 per 100,000. As for the second question, it is absolutely possible to achieve that due to a number of breakthroughs. The first breakthrough with cervical cancer came with the test for pre-malignant disease, i.e. the cervical smear, commonly known as the Pap smear. The second was identifying the natural history of the disease. The third and most important breakthrough came with identification of the causative factors, namely human papillomavirus. The Pap smear was first described by George Papinicolau, who was an American physician of Greek origin in the early 1940s. Unfortunately, it was not till the late 1980s before the widespread use in a systematic approach to cervical screening in the United Kingdom and Scandinavian countries with coronary recall system was implemented. In these countries where it has been widely implemented, there's been a significant reduction of cervical cancer mortality. Cervical cytology has a number of advantages, especially being that it's widely available and it's inexpensive. However, it does require appropriate trained cytologists. The second breakthrough came with the understanding of the natural history of the disease. This unfortunately became known as the unfortunate experiment. Essentially, Herbert Green, a New Zealand professor of obstetrics and gynecology, didn't believe that cervical abnormalities were the precursor of cervical cancer, and he was concerned that the aggressive surgical approaches would lead to infertility. With this as his null hypothesis, he set out to observe women with cervical abnormalities without offering treatment. Unfortunately, and not surprisingly, a number went on to develop cervical cancer. The third breakthrough came in the identification of human papillomavirus as being the causative factor of cervical cancer. In 1976, Harald Zurhausen published the hypothesis that human papillomavirus played an important role in the causation of cervical cancer. And then in 1983, HPV 16 and 18 were identified in cervical cancer. As a result, the physicians involved in that vital piece of work shared a Nobel Prize in 2008. So what do we know about human papillomaviruses? Well, we know that there's over 200 different subtypes of HPV. We know that cervical cancer is caused by more than a dozen of what is regarded as the high-risk types of HPV. We also know that type 16 and 18 is responsible for 70% of cervical cancers. Putting all this information together, we now have a clear picture of what happens. HPV is common. Nearly everyone who is sexually active will get infected with HPV at some point in their life. Having an HPV infection is not an issue. It is the persistence of HPV infection that causes the cervical dysplasia. Cervical dysplasia is a two-way street. It can lead to changes which will spontaneously regress. The less severe the changes, the higher the probability that it will regress back to normal. Therefore, this is a two-way street. The problem is, the further down you go down the street, the harder it is to get back to your home. In terms of types of HPV, we know that there's a global variation in the subtypes across different continents. However, if one looks at types 16, 18, 31, 33, 45, 52, and 58, you can see that over 85% of cervical cancers anywhere in the world will be caused by one of these viruses. In the second part of this presentation, I'd like to talk about the burden of HPV and its prevalence in other diseases. The aim is to review the implications of HPV beyond cervical cancer. As you can see from these pictures here, a part of being responsible for cervical cancer and cervical dysplasia, HPV is also responsible for a number of other diseases in women, such as vulval, vaginal, anal, dysplasia, and cancers, as well as genital warts. In men, a part of being responsible for genital warts, it is also responsible for penile cancers and dysplasia, as well as anal, and is responsible for head and neck cancers. I'm sure you're going to be familiar with this particular pyramid. This basically reflects the burden of HPV-related diseases in both men and women. However, I'd like to point out your attention to this. Annually, if one looks at the overall rate, HPV-related cancers represent nearly 9% of all new cancers in women. So let's look at this in a little bit more detail, beginning with head and neck cancers. Head and neck cancers are the 6th most common cancer diagnosed worldwide. Overall, 30% of oropharyngeal cancers are caused by HPV, but there's a significant geographical variation. So less than 20% are due to HPV in less developed countries, with approximately 40% of cases being due to HPV in Europe, America, Australia, New Zealand, Japan, and Korea. And whilst there's been a declining incidence in tobacco-related head and neck cancer, there has been a rapid increase in the rate of oropharyngeal cancers associated with HPV, especially with tonsils and the base of the tongue. Looking at data from the United States, whilst there has been a decrease in cervical cancer, there has been a doubling of HPV-related oropharyngeal squamous cell carcinoma over the last 15 years. You can see here in the graph as well, cervical cancer is coming down, and now oropharyngeal superseding cervical cancer. Interestingly, oral HPV prevalence is significantly higher in men compared to women, which may explain the higher risk of oropharyngeal cancer in men compared to women. Most of you will have heard of the actor Michael Douglas, and some of you will also know that he had cancer of his tonsil. He came out publicly to say that this was HPV related due to oral sex. So as you can see, the burden of HPV related head and neck cancers is increasing in the Western world. Moving on to HPV prevalence and vulvar cancer, a retrospective cross-sectional study of over 1,700 specimens taken from 39 countries showed that the positive prevalence of HPV in vulvar cancer was 22%, and that the prevalence decreased with increasing age of diagnosis. Interestingly also was that there was a significant geographical variation. Over half the specimens studied were from Europe. Despite that, Europe had the lowest prevalence compared to Africa and North America. What about HPV prevalence in vaginal cancer? Well, again, another retrospective cross-sectional study from 31 countries found that the overall HPV DNA prevalence was 74% in invasive vaginal cancer, and the prevalence decreased with age of diagnosis. However, compared to vulval cancer, there was little geographical variation. So 75% of vaginal cancer is caused by HPV. What about anal cancer? Well, the rates of anal cancer were significantly higher in the period 2008 to 2012 compared to 1998 to 1992 for both men and women in high-income countries. The increases seen were highest in individuals less than 60 for both men and women. And this was across all races and across all stages of diagnosis. What about penile cancer and HPV? Penile cancer is rare and most commonly affects men between the ages of 50 and 70. Incidence rates are higher in less developed countries, where it can account for 10% of male cancers in some parts of Africa, South America, and Asia. A cross-sectional study obtaining specimens of high-grade squamous lesions and penile cancers from 25 countries showed that HPV DNA was detected in a third of penile cancers and in 87% of high-grade lesions. Finally, it is important to talk about HPV-related warts. It's estimated that 90% of genital warts are caused by HPV 6 and 11. To put that in perspective, overall, the global annual incidence of new cases combining both men and women is between 118 to 205 per 100,000 people, with the overall prevalence ranging from 0.13 to 0.56 of the population. The problem is that the reporting of genital warts is inconsistent and data is lacking from certain parts of the world. If one looks at Europe, the estimated number of new genital wart cases is between 376 to 427,000 women versus 379 to 510,000 women. So to summarize, although HPV has become synonymous with cervical cancer, I hope I've been able to show you that its actual footprint is much bigger. In the final few slides, I'd like to discuss the WHO's call for action to eliminate cervical cancer and HPV-related diseases. In May 2018, the WHO Director General Dr. Tedros called for all countries to take action to help end the suffering caused by cervical cancer. Quote, "No woman should die from a deadly disease that is both preventable and curable." Unquote. So we have the tools and we know how to prevent and cure cervical cancer. So the good news is that we actually know what to do, but the question is, how do we get there? The WHO, in a landmark strategy, for the first time brought the three key pillars, including vaccination, screening, and treatment. This became known as the 90-70-90. So the strategy was to vaccinate 90% of girls between the ages of 9 and 14, to screen 70% of women at least twice with a high-performance test by the age of 45, and that 90% of women with a pre-cancer or cancer should receive the appropriate care and treatment. So what impact would this strategy have on low and middle income countries? Well, if we did nothing, the incidence would remain the same at 20 per 100,000. If we were to introduce vaccination only, which is the green line shown here, the one furthest to the right, we would eventually eliminate cervical cancer. But it will take us over 100 years to get there. If we introduce vaccination and one lifetime screen, we would shift the curve, which is the blue one shown here, to the left. And if we introduced 2 lifetime screens, we would shift the curve by 15 years. What does that actually mean in numbers? So if we maintained status quo, the incidence would be 19.8 cases per 100,000. If we introduced HPV vaccination, we would reduce the incidence to 2.1 per 100,000 women years. So that would actually avert 61 million cases during this period. The problem with this is that we would only be eliminating cervical cancer in 60% of low to middle income countries. Now, if we introduce girls only HPV vaccination and 2 lifetime screens, then we would reduce the incidence to 0.7 cases per 100,000 women years and avert 73 million cases. And most importantly, would be eliminating cervical cancer in 100% of low and middle income countries. What about the elimination of cervical cancer in high income countries? If one compares Australia with America, Australia, which has introduced screening and vaccination earlier compared to America, will achieve the elimination of cervical cancer by 2028. This is 10 to 18 years earlier than the United States, and that's simply through an earlier introduction of the vaccination. So WHO set out a target to be achieved by 2030, which is a 90-70-90. So by 2030, 90% of girls should be fully vaccinated by the age of 15. 70% of women should have received 2 high-precision tests by the age of 45. And 90% of women identified with cervical dysplasia or cancer should have had access to treatment. That has become as one of the SDGs. So to conclude, HPV-related cancers can be eliminated through universal vaccination. I think there was a missed opportunity by the WHO in not addressing the other types of cancers which are HPV-related and simply focusing on cervical cancer. We need to go beyond female vaccination. We need to think about gender-neutral vaccination. But this is a topic for another day. I'd like to thank you all again for your time and your patience, and hope that you found this useful. Thank you.
So, on behalf of the organizing committee, we are thankful to Dr. Karim for his really wonderful talk. So now I would request my colleague to kindly introduce the next speaker.
Now we are going to have the second speaker of the session, Professor Dr. Saeed Khan. He is affiliated with the Royal University of Health Sciences And his research interest is in the area of the HPV testing and its importance in the cervical cancer. After completing his PhD in microbiology from Karachi University, Dr. Saeed proceeded to the USA for his postdoctoral research study in the area of molecular virology. Dr. Saeed is also serving as a focal person for provincial public health laboratories at Joy University of Health Sciences. He is the Vice President of Pakistan Biological Safety Association, also serving as a country ambassador for American Society of Microbiology and General Secretary for the Association of Molecular Pathology. Apart from that, Dr. Saeed is also a member of hearing committee to provide the expert opinion recommendation against campaign vaccine outbreak emission, and is also a member of the Provisional Coronavirus Task Force, President Chief Minister Malaysia, and focal person for COVID-19 testing at Dog University of Health Sciences, Oja. And in addition to all this, he is having a long list of achievements, but because due to the restriction of the time, I will just invite Professor Saeed to deliver his talk entitled HPV testing and its importance in cervical cancer and prevention and effective test in routine diagnosis.
Bismillahirrahmanirrahim. Assalamu alaikum and good afternoon. I think it's good or bad to be the last speaker on the session. People are waiting just for the concluding session, so I would like to start right away. Thank you for inviting me on this forum and thank you for the generous introduction. HPV is already been talked much since I think last 3 days, and the earlier presenter explained very well. We would like to bring some local perspective because some data from Pakistan we would like to share. HPV is a DNA virus. As most of you know, there are two types of viruses, DNA and RNA. It's a DNA virus, and it's strongly correlated with the cervical cancer and genital wart. So, as mentioned in other lectures, it's a preventable cancer. Once we diagnose it at the right time, and the cervical cancer is linked with HPV, so we can prevent it before the cancer occurs. The previous presentation was emphasizing it's not just HPV. We need to have consistent infection, and then it can lead to cancer. So before that, it's converted into cancer. If we diagnose it, we can prevent the cancer. So it is the most common viruses transmitted sexually, sexually transmitted virus. And it can, again, I'm emphasizing, it can be prevented even during the transmission as some steps can be taken. It's a DNA virus, but it is quite variable. A lot of changes occurs, and that's why we have more than 100 genotypes or subtypes of this virus, which include the oncogenic strain, less oncogenic, and more oncogenic strain. We will be discussing in a while. This is the genome of the virus. We don't want to go in details, but some of the genes which are oncogenic, some of the genes like L1, which are more of interest in diagnostics tools, that's easy to target. This is more, we can say that it's the ideal target for the diagnosis. Other genes we can have other interest in, but coming to the cancer, can cause many cancers. HPV has the potential to start the oncogenesis based on the region it's hitting or targeting. So the majority cause vulvar cancer, cervical cancer, and this is the percentage of HPV involvement in different cancers. So you can imagine how dangerous this virus is and how easy to control this cancer if we can diagnose at the right time. So that's why the previous presenter and the WHO said that a woman should not be died due to any of the cancer or disease which can be prevented or which can be cured. So this can be prevented if we diagnose. So it is the third most common cancer worldwide based on the data, and some data says the fourth one. and some say the third common one. We have low risk HPV, genotypes of subtypes, and high risk HPV. The genetic makeup makes this more oncogenic and less compared to less. HPV 16 is on the top. More than 90% cancer causing viruses is HPV 16, and followed by 18, and then we have other subtypes which causing different sort of cancer. This is the incidence versus mortality also of different cancer. You can see the HPV, the cervical cancer on number 6 is in both gender, and on the third is only in women, and this is male and female both. We have 16 and 18, as I mentioned. The major culprit of the causing cancer is 16, followed by subtype 18. So if we only detect 16 and 18, we can still prevent a lot of cancer causing virus. There data indicating that the worldwide HPV is responsible for more than 69% cancer worldwide, but in Pakistan it is even more high, about more than 88%. And this is due to poor awareness. We hardly know about what is HPV, what is cancer, or what is cervical cancer. And then late clinical presentation, people don't go to clinics until it's too late, and hardly very proper diagnosis facility available. And many others that we'll be discussing. We published this data long before that HPV 16 was found one of the common reasons for the cancer. We took cervical cancer tissue and looked for the HPV. So majority cases were HPV positive, like more than 98%. It was the known cancer tissue. And among those, 98% were type 16, followed by type 18. Looking into this data, we further looked the HPV in women who were visiting the gynae clinic. Those were not the known patient, rather they were just visiting the gynae doctor for different issue. And we collected 360 samples, PACS, cervical scrapping, and looked for HPV if there's an HPV or not. And the results was quite dangerous, you can say, or very high positivity ratio that we achieved. About 19% women were positive for HPV. Out of them, 15% were the highest HPV. So it is quite alarming that the women who are just visiting the clinic for gynecological issue, and randomly we collected samples, and among them 19% were HPV positive, followed by 15% highest HPV after doing the genotyping. So this number is quite alarming. This data is not yet being published, but we will publish it soon. This is the distribution of different genotypes. As I mentioned, that there are more than 100 genotypes. Among them, few are very high oncogenic and some are comparatively lesser. Though we have this clear indication that HPV is linked with cancer, cervical cancer, beside that, hardly you can see that people get treated for HPV. There are a lot of, we tried to bring it in the routine diagnostic list, as like hepatitis C, hepatitis B. We receive thousands of samples every day for hepatitis B, hepatitis C, but we don't receive a single patient who is coming for HPV PCR or HPV screening. So this is a lot of things when we study that. Stigma is one of the things that is the big hindrance. A lot of people think that it's a sexually transmitted disease, so you have to go to a doctor. You have things in mind that it's sexually transmitted disease. Then people feel shy, anxiety. A lot of people that don't have knowledge that this could be possibly due to the HPV awareness program. We don't have accessibility to resources. We don't have easy access to HPV screening. Then if you arrange the screening, then there are reluctance and people just not present. They will go away and they won't participate in the screening process. hesitation to come to the doctor, and awareness about the vaccination, socio-cultural characteristics, lack of sensitive diagnostic tools is another, and financial, though it's on a top issue, but though we provided a free testing, again, there were very few people who participated in the screening process. So these are very critical points which are preventing the large-scale screening and bringing this HPV screening as a routine test. We have a lot of vendor or companies who want to participate even for free screening, but when we come in the field and try to access women, particularly girls, then they have a lot of hindrance or hesitation to participate in that. Otherwise, I think the data indicating our data as well as the rest of the world data, the HPV is linked with cancer, and if we diagnose it early, we can prevent the cancer and reduce the disease burden. Every day, as mentioned, a lot of people are dying because of the cervical cancer, which is majority is HPV linked. Then we can reduce burden on our economy or health because a lot of money being spent treating the cancer patient. So if we prevent those patients to be converted in cancer patient, a lot of money can be saved and it can be used for saving lives or other diseases or infectious diseases. It prevents overburdening of the public health resources. So we can mobilize those resources for other things that we can save those patients not to be converted into cancer patients. There are prevention, a lot of resources that can be mobilized and efforts that can be done at the right time. Like at the early age, vaccination of HPV can prevent the cancer, particularly under the age of 15. If vaccination program is like this of COVID or other vaccination program, we can move it and we can have this. We can increase the awareness in boys and girls as well. The use of contraceptive and male circumcision also play a role in the prevention of the HPV transmission. Same, we should do screening for women more than 30 years age or sexually active women. So we need to screen them properly, routinely for HPV. And if there's any cancer patient, we need to properly treat them so they can have proper treatment on time. So HPV won't spread continuously, or we don't need to spend a lot of money on more and more patients. So the point is we need to reduce the burden of HPV at exactly directly proportional to prevent the cancer patients. So in this case, a lot of practice can help, like counseling is one of the practice that will be instrumental and helpful if we do the counseling between the healthcare provider and the patient or any of the participants who need the counseling. And this counseling needs, as I mentioned, a lot of stigma related, a lot of anxiety or barriers are there. So that can be provided privately, woman to woman, especially that works better. And to take the personal information and confidentiality into account, we can increase the number of screening that it is helpful. We can keep the data confidential, and it is not always that stigma should be bring in the middle. We can reduce the stigma by counseling and encourage the young women particularly for screening. Then the use of media, particularly, again and again, I'm emphasizing that cancer is directly linked to HPV, and HPV is preventable if we can screen it properly. We can reduce this burden of HPV and cancer. So, as we can talk about hepatitis C, it's very easy. But when it's come to sexually transmitted diseases, it's very difficult, even for doctors and people who come on the media, it's become difficult. So we need to talk because we have social culture norms. We need to keep them intact. We want to breach them, but still we have a space to talk. If we won't talk, we can't resolve the issue. So the media are playing a vital role, and that's why we need to speak up about such issue and bring some experts on the topic and talk to girls like here we have, they can be ambassador, they can preach and spread the words, and they can counsel their peers and colleagues, and also the family members that what exactly HPV, if there any symptoms like HPV, we can talk about it. We need to know where to go, where's the doctor to contact, where we can do the screening, and there's nothing to shy about, and we need, because HPV is a killer. So do we accept with cancer or HPV, or we accept to go to a doctor, proper doctor who can properly screen us and provide us the proper screening, and if there's any early detection, there are a lot of options available at the treatment level, which can be done at early stages. So this is the take-home message for everyone, that we should educate ourselves first. We should educate our women, girls, and women, young age, and even mothers and elderly women. They can play a vital role by educating the young girls that what exactly the HPV or any sexual transmitted diseases about the sexuality, though is very sensitive topic, especially in our culture. It's not that easy to talk about it, but now there are a lot of forums that we can get information from, and we have access to the information, and we need to talk about it. HPV testing is available in different labs. Unfortunately, majority of the labs, they don't get samples. Even you name it, the top most labs, well known, well recognized, they don't get samples for testing. So there is a big barrier between this issue to get to be screened for HPV. We, as a scientist, researcher, can play a role in it, and from this forum, I will just emphasize that we need to speak about it, and at the right forum with the right person, so we can get rid of the HPV and the cancer, particularly cervical cancer. Thank you very much. I think I have ended on time. If there's any question, I will be more than happy to answer.
Thank you, Dr. Saeed. We have a couple of minutes, so we can take at least 2 to 3 questions.
Yes, my
Thank you so much. Sir, my question is that there are a lot of clinical people who also are obstacle for this treatment. What will start say about these people?
sorry, I couldn't understand your question. Where is the question?
Yes, sir.
So what is the question about?
They are also obstacle that they don't allow the people who are not good for them to take or screening test, etc. for HPV.
Take the mic away from the mouth and then you can ask the question.
Sir.
Talking about the cultural norms that about the people who are not very well educated. So how you can somehow help out to screen.
Yeah.
That's what you're asking.
Yeah.
Okay, so it's awareness. A lot of people get aware, but then the stigma that we have an issue with many sexual transmitted diseases. So that's why the counseling will help, because if I can't say many things in front of many people. Okay, I have to taking care of the culture now. So, but at least I can sensitize that if you have such issues, then you should go to the doctor, the proper person to talk to. So that's why it is always important to at least have a knowledge about the issue. If someone has cervical cancer, what was the reason? And we can give an example that we have, like the data, we can present the data. Then a lot of people have, if you go to the cancer hospital, there are a lot of people suffering from cervical cancer. So if we can like put the data, the reality in front of them, we can make them understand. So I think the counseling will help, the awareness, spread of awareness will help, and to bring people who are more important for them to listen. Sometimes people won't listen me. Dr. Mitchell would be the right person who to such people. Even religious leaders can play a role. So that tactic of counseling may help, and then we provide the facility. We just speak on about the burden, and we don't have a facility available, a lab, we don't have a lab, and then the financial issue. So overall, holistic approach should be adopted.
Definitely, most of the religious people are also unaware of the disease like HPV. So we also aware these people too, like in rural areas.
Yes, of course, we should continue the awareness. There's always people who can be convinced, and there are many who take time to be convinced. So you should continue your efforts, and time will come that right people will play a better role, and we will be successful. You have a question?
Sir, my question is, last of years, HPV, the laboratories are not getting human papillomavirus screening tests. They are unable to get it. They're not getting samples. Is the reason the same, the stigma and everything? Or I think HPV screening, I mean, actually talking about the human papillomavirus DNA test.
Yeah.
Yeah.
We have the pap smear, but pap smear is very limited. Again, it's not that much. If you check, only people will when there is an issue, they will come. They won't do screening. Screening is different than the diagnostics. When there is an outcome of some disease, then only then the doctors collect the sample and send. So the pap smear is coming to the labs, to histopathological labs. Again, we don't have many, but they are coming only when it is usually too late. So the screening is the normal screening that when we are doing hepatitis B, hepatitis C screening whenever we would like to, annually or after 6 months or such routine. So we don't get that screening. I'm talking about that. So even that pap smear is not, nobody is doing the pap smear routinely unless you someone go to the gynecologist for some complications or some disease. Only at that time pap smear is tested. And the DNA testing, of course, it is almost I don't see many of the labs there, though they're having the kits and it expired and they throw it out. But
does this have to do something with the cost of the test?
there are a variety of the list we mentioned. There are costs come once people would like to be tested, but only at the cost. So the cost come because it's quite expensive. The PCR test is really expensive. But as I mentioned, beside that, we have provided many times a study or pre-screening. So a lot of people get reluctant in those, they don't participate, and that's a study. So for some people it's the finance, some people it's the stigma, or many others that I have listed. So it could be
pre-screening, where was it?
And for routine research, another study we will starting. The study that I mentioned, it was pre-study in the civil hospital, and another we are planning next month in Peshawar as well as in Karachi. So about 2,000-3,000 samples we would like to test it for free. So we'll see if people can. If you have a link, if you would like to connect us, people who want to participate, we will be more than happy. But this is our experience that less people participate or hardly people because they are encouraged to participate. So that's what is our experience so far. You think it's the other way? Okay.
But not all taking are selected.
Yeah, that. So why not all people are?
I don't know, but I'm currently no one, not the same for all patients. Selected patients, they are not responding any treatment.
So that is not screening. That is you are looking for some etiological agent. You have issue. Screening is something that you routinely screen. So that is not happening. Even the one you mentioned the study we did it just people who were coming in the gynae clinic, and they were just checked for HPV, and the burden was about 90%. So you are just supporting my comment that not more people are screened. So either the doctor is not prescribing due to financial thing. In civil, it is, I think, free. Screening is free, but in that case, the
Not
HPV is not okay. The test is not free.
Because Dr. Saeed is already with us.
Yeah, we can continue the discussion.
So you can discuss rest of the questions and queries you have in your mind with Dr. Saeed.
Thank you so much.
And you
Yeah,
are
sure.
available. Now we all have to proceed towards the auditorium for the closing ceremony. Thank you very much.
Thank you so much.